Good morning. I am Dr. Vinod, Professor of Anesthesiology, working in Sree Balaji Medical College and Hospital. Today, our topic is going to be on stellate ganglion block through the Gofeld's approach. The specific learning objectives of this topic is, at the end of the session, the student should be able to identify what a stellate ganglion is, what are the contents of the stellate ganglion, where is it present, and how to block it and approach it safely. What is the stellate ganglion? Stellate ganglion is formed by the fusion of inferior cervical ganglion and the first thoracic ganglion. It is a star-shaped ganglion and it is seen only in 80% of the individuals. It supplies the sympathetic supply to the upper limb, head and neck, as well as the heart. So this ganglion is located in the neck and it extends from the first rib and it extends up to the transverse process of C7. And you can see in this picture that C6 level will harbor the middle cervical ganglion. So what does the stellate ganglion contain? It contains the sympathetic fibers which arise from the preganglionic neurons of the anterolateral gray horn of the first few thoracic segments. They exit the spinal cord through the corresponding nerve root, reach the sympathetic ganglia through the white rami communicanthus, where they ganglionize and they will reach the upper limb through C7, C8, T1, and the preganglionic sympathetic fibers to the head and neck traverse through the superior and the middle cervical ganglia. This picture will show the pathway which is traversed by the sympathetic nerves from the spinal cord to the ganglia. The most important part of this block is knowing about the relations of this stellate ganglion, because the stellate ganglion is related closely to a lot of vital structures which, when accidentally injured, could result in fatal conditions. So this ganglion is bounded anteriorly by the carotid artery, vertebral artery, medially by the esophagus, trachea, thyroid gland, longus coli and recurrent laryngeal nerve, laterally by the anterior scalene muscle, posteriorly by the transverse process. In this picture, you can see the cross section of the neck at the level of C6 and C7. Though the stellate ganglion is present at the level of C7, it is very much closely located to the vertebral artery. So any attempt in blocking the ganglion can result in accidental injury to the vertebral artery, thereby jeopardizing the blood supply to the posterior half of the brain. On the picture on the right side, we can see the ganglia which is present at the level of C6, which is the middle cervical ganglia, is quite away from the vertebral artery, where the vertebral artery has already entered into the transverse foramen. Now coming to the branches of the stellate ganglion. The gray rami communicanthus pass to the C7 and C8 from the ganglion. Fine filaments form the ansa subclavia to form the subclavian plexus on the subclavian artery, thereby supplying the upper limb. Larger filaments move along into the vertebral plexus along the vertebral artery. The inferior cervical cardiac nerves join middle cervical cardiac nerves to form the deep cardiac plexus. This picture once again shows us the branches of the stellate ganglion. Here in this picture, we can very well see the vertebral plexus encircling the vertebral artery, as well as the sympathetic supply going into the upper limb through the subclavian artery. When should it be blocked? So now we are entering into the most important part, which is the indications. When this sympathetic ganglion can be blocked. So the first indication is complex regional pain syndrome 1 and 2 of the upper limb, vasculopathies, both acute and chronic vasculopathies, arteriospasm which occur immediately after embolectomy, or inadvertent intraarterial thiopentin injection, which are the acute conditions which can cause vasospasm, as well as chronic conditions like Raynaud's phenomenon and systemic sclerosis. Herpes zoster, intractable angina, head and neck malignancies, phantom limb syndrome, sudden sensory hearing loss, hyperhidrosis of the upper limb, Bell's palsy, cardiac arrhythmias which are stable in nature, quinine poisoning, hot flushes and vascular headache. So in this picture we have two of our patients. On the left side, the patient was having severe post-herpetic neuralgia which was refractory to conventional treatment. So this patient benefited from the stellate ganglion block. And the photo on the right side shows a patient suffering from complex regional pain syndrome of the right upper limb. And this patient was also refractory to conventional treatment like NSAIDs and gabapentin. And this patient, we gave the stellate ganglion block at an interval of 1 month for 4 times, and it helped that patient immensely. So how to approach this nerve safely? So there are 3 techniques. The oldest technique is the landmark guided technique. The one which came out later or in the 80s or 90s is the fluoroscopy guided technique, which may be either paratracheal or the oblique approach, and the latest one is an ultrasound guided technique. This can also be either paratracheal, and the latest approach is the Gofeld's approach, where it is an hybrid technique which integrates both the CM as well as ultrasound in effectively providing the block. So let's have a look at the oldest technique, which is the landmark guided technique. The landmark guided technique, what we usually used to do is place the patient in the supine position, head and neck in the neutral position, and we will extend the neck. Then the performer of the block would be standing in front of the patient, and he will be palpating the carotid artery, and he will lateralize the carotid artery at the level of C6, and he will introduce the needle medial to the carotid artery. He will advance the needle until it encounters the transverse process of C6, and once when it encounters the transverse process, he will withdraw the needle slightly and he will inject the drug. So the major drawback of both landmark and fluoroscopy guided techniques are, first, the position of the C6 tubercle. Though the C6 tubercle is the largest when compared to other tubercles of the cervical spine, there may be possibilities where the C6 tubercle may not be as big as it should be. If the tubercle is accidentally missed, there is every possibility that the vertebral artery or the C6 nerve root may be injured. The next problem is variation in the point of entry of the vertebral artery into the transverse process. See, though the vertebral artery enters at the level of C6, there are possibilities in 7 to 8% of patients where the entry level of the vertebral artery may be at the point of C4 or C5, thereby exposing the vertebral artery to injury. And the third important point is arterial puncture can be only identified after the puncture is made in both landmark as well as fluoroscopy guided technique. In addition to that, the soft tissue pathway which is traversed by the needle cannot be assessed in case of a landmark or fluoroscopy guided technique. And the important point in this is, though esophagus is considered as a midline structure, in 40 to 60% of the patient, esophagus lies more towards the left. So whenever the left side stellate ganglion is approached, there is possibility that the esophagus might be injured. In addition to that, small subset of patients will also be having a diverticulum in the esophagus, thereby once again making them more prone for injury if it is not approached by the ultrasound guided technique. Now coming to the Gofeld's approach. So as I've already told you, Gofeld's approach is a hybrid technique. It will combine both the benefits of CM as well as ultrasound, and it will reduce the side effects to the minimum. So while positioning for this block, the patient has to be placed in the supine position, head turned towards opposite side of the block and the neck extended. A linear frequency probe with a frequency of 10 to 15 megahertz is used in this block. The local anesthetics which can be used in this block are either 0.25% bupivacaine or 0.2% ropivacaine. The total volume would be around 5 to 10 ml. And we will be using a 22 gauge Queen key spinal needle. So prior to the procedure, the patient would be shifted to the operation theatre. The patient has to follow the nil per oral guidelines for at least 6 hours, and minimal mandatory monitoring is necessary in this patient, which includes ECG monitor, SpO2 monitor, NIBP and ETCO2 and temperature monitor. In addition to that, we will start an IV line and we will administer a procedural sedation. Being a procedure of the head and neck, the patient will be in a very anxious mood. So in order to allay that, we will give adequate amount of midazolam, a benzodiazepine as well as opioids. After positioning the patient, a PA view of the cervical spine is obtained with the help of a C-arm and the patient is painted and draped. The probe, now the ultrasound comes into play. Now the probe is placed in the neck at the level of C6 and a scout scan is performed, and we will visualize the following structures. Structure number 1 would be the C6 tubercle, the adjacent carotid artery, the internal jugular vein, the longissimus coli muscle, the thyroid gland and the trachea. Now the needle is advanced from the lateral to medial and the needle is introduced between the carotid artery and the Chashignax tubercle in an in-plane technique. The needle is advanced until the level of longissimus coli muscle. Once when the prevertebral fascia in front of the muscle is pierced, the needle tip is positioned between the prevertebral fascia and the longissimus coli muscle. 1 ml of non-ionic contrast dye is injected and the fluoroscopy image is obtained once again to identify the spread of drug. Now we can see 2 pictures which is showing the spread of the dye in the cephalocaudal direction from C4 to T1 in the subfacial plane between the prevertebral fascia and the longissimus coli muscle. After the ideal needle placement, which is between the fascia and the muscle and ensuring the spread of the dye, we administer 10 ml of the local anesthetic along with 40 mg of depot methylprednisolone, and it should be injected incrementally after repeated aspiration. The pain relief would be recorded at the end of 40 minutes after the procedure, and we will look for the triad of Horner syndrome, namely enophthalmos, ptosis and meiosis of the pupil. Ptosis following stellate ganglion block. See, we can see the ptosis in both these patients. The block was performed on the right side and the patient has developed ptosis. So, while summarizing the Gofeld's approach, see, it provides a safe needle pathway. So, the pathway is a relatively avascular. It doesn't pass through any one of the vessels and it does not injure any of the soft tissues that are present in the pathway. It being a subfacial injection, the drug spread is restricted to the layer between the fascia and the muscle, thereby avoiding accidental blockade of the recurrent laryngeal nerve. Though the stellate ganglion is present at the level of C7, this block can be performed at the level of C6, thereby avoiding injury to the vertebral artery. And we have also seen what are the indications and what are the sympathetic fibers that will supply the upper limb, heart, head and neck, how to block it safely at the level of C6. So at the end of the session, it is very clear that Gofeld's approach to stellate ganglion block is a safe blocking pathway because it avoids all the vital structures that is present in the neck as well as ensures 100% blockade of the ganglion. Thank you.